afternoon. My name is Brian Rowe. I'm today's presenter. I have a few small housekeeping duties. This presentation today is called Pathways of Care and Investigation for Acute Concussions. Before we get started, I wanted to mention that the webcasts are part of a larger joint initiative by the Government of Alberta called the Human Services Learning Series. For more information on this series, check your emails for regular updates or go to the hslearningseries.ca website. You can see that on the slide here for upcoming sessions. You will be able to follow on Twitter at the username AB Human Services. Today's session is also being recorded, and the video will be posted on the ABII webpage after the live recording. By way of introduction, again, my name is Brian Rowe. I'm a professor of emergency medicine at the University of Alberta in Edmonton, and I'm what's called a Tier 1 Canada Research Chair funded by the Government of Canada to do research in evidence-based emergency medicine. One of the areas that we're interested in and have been working on are head injuries in the emergency department. And I'm also the scientific director of the Institute of Circulatory and Respiratory Health at CIHR and the Emergency Strategic Clinical Network. The network is an AHS initiative to link emergency departments, providers, administrators, researchers, and clinicians across the province. And one of the important initiatives that we're working on is a PRIUS project funded by AIHS and Alberta Health Services, led by Eddie Lang and his group in Calgary, to look at reducing the risks of exposure to CT scans for mild traumatic brain injury. So that leads in well to the discussion that we are going to talk about today. So this is the title again, and my funding comes from these organizations. I have no specific affiliations with a commercial organization that may have a direct or indirect connection to the content of this presentation. I am an emergency physician. I work at the University of Alberta Hospital, and I see a lot of patients with concussion in the emergency department, and our goal really is to improve the care that's provided to those patients suffering this condition. The patients in the clinical cases have provided consent. Some of the NHL players, football players, and other movie stars and actors and actresses have not provided consent, but their photographs are available on the website. So I think we're protected in that case. So minor traumatic brain injury or concussion is a common problem in the emergency department across many developed countries like Canada. Everyone knows somebody who's had a concussion, and the more you talk about it, the more you hear the story about minor traumatic brain injury or concussion. There's a wide variation, so some people have a bonk on the head and they feel a bit dizzy and they have a headache, and they recover quite well in a couple of days and are back doing their regular activities fairly quickly. But some people have severe injuries, and they can have persistent symptoms for a long time. And these transient symptoms are not bothersome to people after they resolve, but the long-lasting symptoms can be really devastating and can cause significant impairments in the quality of life for patients who suffer a concussion. There are other consequences of long-standing symptoms, such as depression, that are well documented in the literature. I think if any one of us was active and suffered a concussion that had long-lasting consequences, it would be unusual for you not to be depressed about your health problems. So our goal is to try to reduce the severity of the concussions through primary prevention and through secondary and tertiary prevention to improve the outcome for patients who suffer this often devastating consequence. So it's a confusing term. We've already used mild traumatic brain injury and concussion in the presentation. We're only on slide 2. There have been some really important events related to head injuries. When I was a kid growing up let's just say a long time ago, lots of people had concussions, but it was the kind of thing where you grinned and bared it, you got back up, you toughened up, and you went back into a game, or you went back into your activities. So this is Natasha Richardson. She's a woman who was skiing in Quebec without a helmet, had a very inconsequential fall onto very hard ice at a ski hill. She had suffered a head injury, but awoke after a brief period of loss of consciousness, went back to her room, and then was found by her husband, another actor, and she had had a bleed in her brain, and by the time they got her to definitive care, it was too late, and she died. Another person that's familiar to you now, the Stanley Cup champion captain, Sidney Crosby. And Sidney had a severe concussion in an outdoor game that was, in many people's opinion, missed, and later suffered a pretty insignificant injury, but was out for a prolonged period of time with a post-concussion syndrome. This is Benedict Malo, the person who first identified chronic encephalopathy, traumatic encephalopathy, or CTE, and a movie was just recently released documenting his career and his life, trying to determine the causes and consequences of the premature death of professional athletes. This is Derek Boogaard, who's a former Minnesota Wild enforcer. You can see the size of his fists. He died and was found to have had CTE. And then Junior Seau, a personal favorite of mine, a professional football player with the San Diego Chargers, who also died prematurely in a violent act, and also was found to have CTE. So these were important events. I think probably Sid Crosby's concussion was the most important event for concussion research. Many people were surprised at the length of time he stayed out of hockey, and the amount of discussion about what needed to be done for his care. And fortunately, he's returned to a very productive career, but had a very long absence from the ice. So it's an important bit of history that has helped us move the agenda forward with concussions. So there are many causes. These are high-profile people. You see a lot of work being done on elite athletes. Baseball, football, hockey, basketball, soccer. These guys that are making millions of dollars playing professional sports. But the large majority of concussions and traumatic brain injuries are in regular people like you and me, who are, maybe playing a sport or driving a car or going for a walk, and you suffer a concussion that is not in an elite athlete, seen by a medical professional at the time of the event, or managed by a trainer under strict supervision. So the most common causes are things like motor vehicle collisions. Assaults are common, falls. So particularly in the wintertime in Edmonton, we see lots of falls in the emergency department where people have hit their head and they have a laceration, but they also have a concussion. Obviously, the sports, we don't see many elite athletes in the emergency department. I'm not trying to be insulting to some of you out there who think you might be elite athletes, but quite frankly, the majority of the people we see are recreational athletes, people trying to stay fit and enjoy a pastime. There are some, approximately 10% of work-related, of concussions are work-related, and then there are other minor causes. So it's not just elite athletes that get this. This is a picture of what we think should happen to people with concussion. This is the old TV show ER. You can see the fellow on the left-hand side was formerly voted the sexiest man alive. The woman on the on his immediate left is now a famous movie star and actress, and the other three guys have not been seen before or since. And I think several of them are working here in Edmonton. But the reality is that this is the way we should be treating concussions. They should be taken seriously. And unfortunately, what happens is this is how it's treated. You get a number and you wait. in the emergency department. So it's important to bring somebody with you, a patient advocate who can help to tell your story, particularly if your memory of the event is impaired by a loss of consciousness or memory impairment. So I'm going to give you a couple of cases. I think it's important for you to visualize what happens to patients. This is a 63-year-old female, very fit. She was riding her bicycle with her helmet on. It was a sunny day. There was no environmental impairment. There was no obstruction. And she inadvertently entered an intersection and was run into by a fairly large vehicle and flew over the car hood onto the road on the driver's side of the vehicle. She had a loss of consciousness, and you can see her face. She sort of skidded along the roadway. Fortunately, there weren't any other cars coming, and she survived this event, but you can see lots of abrasions. You can see her right eye is almost completely shut from swelling, and this is almost immediately after the event. She was transported to the emergency department by our emergency medical services teams, and I note here that her Glasgow Coma Scale, or her level of consciousness, fluctuated during the transport. So they were very concerned about her. She came to the university hospital, and you can see here her bicycle helmet. So clearly without a bicycle helmet, she would have had a difficult time surviving or surviving intact in this event. You can see the helmet is cracked in half on the upper side and the underside. This is a helmet, obviously, that is a typical bicycle helmet and thought to be effective in reducing face and head injuries in the event of a crash. So the second case is there was a women's hockey tournament in Edmonton. A 17-year-old female fell onto the ice after being pushed. She had her helmet on and a mouth guard in, and there's some evidence to suggest a mouth guard helps to improve or mitigate concussion symptoms. She had no loss of consciousness, but on the bench she felt a little dazed and dizzy. She went back onto the ice for her next several shifts, and then came back to the sideline, had one episode of vomiting, so she was taken out of the game. Her family was from another city, so they brought her to the emergency department at approximately midnight. She was by that time feeling well with just a mild headache, and there was no neurologic examination, so she was planning to travel back to Calgary that night. And then finally, we had a resident colleague who was training at UBC Kelowna, came back for winter holidays, and was rear-ended while turning left on an icy highway in the Christmas holidays. She had minimal vehicle damage, so that wasn't a problem, but her neck was turned looking sideways to make her turn to the left, and she had what's called a rotational injury to her neck. She had no loss of consciousness that she can remember, but she does describe this episode of the events being like still photographs in her mind. That's described by some patients after an episode. She had no episodes of vomiting. She did return home and said that she had some emotional lability, outbursts at home, but was not seen by an emergency physician, traveled the next day to Creston, BC, which is a small community where physicians are trained. So she had 2 airline trips and a bus ride, so total about 14 hours. She returned to work as a resident in a busy semi-rural practice. So those are 3 cases, pretty typical. One didn't come to the emergency department, one came in an ambulance, another person was ambulatory. So, they come to the emergency department, and our triage nurses in all emergency departments in Alberta would say, what brings you to the emergency department today? And most patients say, I got conked, I bonked my head, I have a concussion, I got knocked out. Those kinds of terms are used. And what happens in the emergency department, the nurses use a triage system called the Canadian Triage and Acuity Scale. And if you get a CTAS 1, you're basically in bad shape. You need to be seen immediately, and your being resuscitated. So these are kinds of patients that come in with cardiac arrest or severe head injury. CTAS-2 would be emergent, so lots of symptoms, a lot of pain, maybe nausea. Very frequently these patients have confusion and disorientation. They should be seen within 15 minutes. CTAS-3 are patients that have an urgent condition. So again, these are used to prioritize patients and how they would be seen in the emergency department. They should be seen within about 30 minutes, 90% of the time. And then less urgent care, the pain is not so significant. You examine well, your vital signs are normal. You would be seen within 60 minutes. And then finally, non-urgent. Doesn't mean you don't need to be seen or you don't need an investigation, but in these cases, 2 hours, 80% of the time. So this is likely how patients see it. CTAS-1, I'm going to get seen pretty quickly. I'm lucky. But really, a CTAS-1 would be an unlucky thing to have. So the perception is very different. And CTAS-2, it won't be too long, so I'm optimistic. CTAS-3, I'm going to bring a book. I'll need to have some patience. CTAS-4, bring a pillow. Your patients will be tested. And CTAS-5 is good luck. You're praying, bring a sandwich, and a book. And this is really just to depict the major problem that's facing many emergency departments in this country, which is emergency department overcrowding. We're overcrowded in the hospitals, which spills down to the emergency department, and our colleagues can't get patients who are admitted out of the emergency department, so you spill over into the waiting room and then into the EMS bays. So we're working very hard in the province to try to improve our response times for patients in the emergency department and our responses to patients with EMS transfer. So just to look at the specific definition, a concussion is a disturbance of the brain function caused by a direct or indirect force to the head. And you need to remember it doesn't need to be a blow to the head. It can be a rotational injury like our young medical staff had. It results in a variety of nonspecific signs, so there's no one symptom. Obviously, headache is a common thing, but nausea, vomiting, confusion, fatigue, drowsiness, all are symptoms and signs that can occur. And most of the time, these concussions don't involve a loss of consciousness. And in fact, a loss of consciousness may reflect amnesia for the symptoms because of the concussion and not really a true loss of consciousness. So it's not a particularly reliable measure unless somebody is there witnessing it. So at a sporting event or if someone is accompanied on an activity like a walk or a bicycle ride. So concussion should be suspected in the presence of any one or more of the following symptoms. So headache, which was case number 2, the young woman who played hockey and fell onto the ice. She had a headache. Physical signs like unsteadiness in their gait, impaired brain function like confusion, difficulty reading, those kinds of things, like the patient in case 1 with the bicycle crash, or abnormal behavior. So the outbursts of emotion and being upset were out of character for the particular person involved, and that was in the case 3. So any of these kinds of things really are important considerations in diagnosing a concussion. So obviously the concussion is, you often don't see anything external. Maybe in the case of the first patient you saw an abrasion. You see some contusion and bruising around the eye, so there's something visible. But many of these patients present and they look perfectly normal, but their symptoms and signs are consistent with a concussion. Again, it does not require the loss of consciousness, so in the past people would say, well, you didn't really have a concussion because you didn't get knocked out, and that is not the case. And I formerly was a coach in competitive soccer. One of our players was running down the field, and a ball hit him on the side of the head because somebody miskicked the ball. This young teenager had a previous concussion as a younger man, or younger boy, and this had required a hospitalization for this. And so the family had already warned us that there was a history of concussion. And we know that a history of concussion causes you to be more susceptible to other concussions. So in this particular case, the young man got up immediately in front of us and said he was fine. He ran down the field and then really wasn't paying attention, wasn't focused, was behaving abnormally, so we took him off. And it turned out that his concussion lasted 6 weeks. He didn't get knocked out. He barely got knocked down. He said he was fine afterwards. So you need to have somebody watching these events to give a confirmation of the diagnosis. So when you come to the emergency department, many times you'll come in and we'll do blood tests and we'll do x-rays and we'll do scans. So what happens to people with concussion? Well, there's no specific blood test at this point. There are some research studies underway to look at specific markers in the blood. But one of the concerns about these tests is they don't differentiate patients very well, and they likely are too expensive to ever be applicable, at least in the near future. Simple imaging, when I graduated from medical school back in 19... we had skull radiographs, but we didn't have CT scans. So we do these x-rays of the skull. They were exposing people to needless radiation. They were often not very clear because you have growth plates in the brain, in the skull, and that's considered old school now. And x-rays of the skull have largely been eliminated as a diagnostic test in emergency departments in Canada. So you may be given a CT scan in the emergency department, and the question would be, does every one of the cases that we had deserve a CT scan or an MRI or something called a functional MRI? These are specific tests done mostly in research purposes. So those are potential tests, and then specialized imaging like neuropsychological testing and behavioral testing. Those are tests that are done, again, after a delayed period of time. They're not done in the emergency department. So you're not going to generally get lab tests. You're not going to get a skull radiograph. And the question is, should you get a CT scan? So there's a program in Canada called Choosing Wisely Canada, and emergency medicine is part of this initiative. It is an initiative where we encourage patients and clinicians, whether it's your family doctor, your emergency doctor, your specialist, a nurse practitioner, or some other health provider in your hospital or your community, to have a discussion about the risks and benefits associated with tests, procedures, and treatments. So this is an initiative that was started in the United States, has moved to Canada in the last 2 years, and the number one top 5 category for emergency medicine is to avoid doing CT scans for mild traumatic brain injury. So it's an important consideration for physicians, for radiologists, and for patients. So again, in these cases, does the patient require a CT scan? In a normal conversation at a meeting, I might ask the audience to put up their hands, and I'd ask if the first patient needs a CT scan, and almost everyone would put their hand up for that patient. The second patient, about half the room would put their hand up to say that that patient needs a CT scan. And then the final patient, the physician, most people keep their hands down because she didn't come to the emergency department at that time. So here's a CT scan. These are sophisticated high-resolution images of the brain and the skull, and you can see the white part, the circle around the brain is the skull bone. It's a very bright white picture, and then the brain itself is situated within that, and it's bathed in cerebrospinal fluid, which is almost like the shock absorber for the brain. These are pretty reasonably easy to get. Almost all of the hospitals in Edmonton, Calgary, and in the regional centers in Alberta have access to a CT scanner. But there are risks associated with having a CT scan. We don't know how many CT scans people can have in their lifetime. So we're trying not to order a CT scan unless somebody really needs it. There is radiation exposure. It's the equivalent of almost a year of regular radiation living in your community. So that seems like a lot. It causes a lot of time delay in the emergency department. I had recently a baseball player who had been bonked in the face and the jaw, who waited 6 hours in the emergency department for a CT scan. Now, he needed a CT scan, but you can see that you could wait a long time and be bumped by trauma, stroke patients, and other conditions to finally get your CT scan. This wasn't in the middle of the night. This was during a Saturday daytime. So that length of time he was, bright lights, exposed to no food, limited rest, and an unpleasant environment to recover from a concussion. And then there are costs associated with it to the healthcare system. And our goal is not to reduce costs, is to allocate costs more appropriately across the healthcare system. So if we can save a CT scan or two in the emergency department, maybe we can do another test on another person with cancer. So it's a global budget for health in the province, and this is not specifically to avoid testing some people to save money. It's to reallocate resources where they're most needed. So again, does everyone need one? So we've done a lot of research over the last decade on something called the Canadian CT head rule. And it's probably not that important for you to know the exact mechanism of it, but the CT scan rule for Canada has been tested in hundreds of thousands of patients and shown to be reliable in the hands of many different physicians and safe for patients. And the goal of this test our tool is to reduce needless use of CT scans. So there are high-risk mechanisms, like if you're confused after 2 hours, you should get a CT scan. If you are vomiting more than 2 episodes, you get a CT scan. If you're over 65, you get a CT scan. Because the brain in 65-year-olds is a little bit smaller than it was when they were 25, and there's a chance that the blood vessels can burst from the injury. So we're a little bit more concerned about those over 65. If you can't remember the event for more than 30 minutes, that's a medium risk criteria. And if you've had a dangerous mechanism, like you fall from height, you're ejected from a vehicle, you're a pedestrian that gets hit in the head by a vehicle, those kinds of things are medium risk, and both those groups should get a CT scan. And what we know is that it's very sensitive, meaning that if you have none of these criteria, your chance of having an abnormal CT scan is like 1 in 10,000. So it's very sensitive to picking up these things. It's not very specific, so if you are positive for these, it's still likely that your CT scan is going to be normal, but we just don't want to miss any serious conditions. So it's one of the things that we know about the CT scan rule is, despite the fact that it's backed by extremely sound evidence and it's developed in Canada, it's known to most emergency physicians, it's still hard for people not to do a CT scan. And we did a study where we looked at 12 centers. 6 of the centers were called intervention centers, 6 were control, and each of the intervention centers did something to try to reduce the use of CT scans. And unfortunately, what we found was that the intervention hospitals, they increased their CT scan rate, as you can see at the top, by 13%, whereas the control hospitals increased their CT scan by less than that. So again, what we're showing here is that even when we really try, it's very difficult to stop physicians from ordering those CT scans or patients from demanding it. And it's important for patients to realize it's not a benign test. It does have adverse effects. It is going to delay your departure from the emergency department. It is costly, and the bottom line is most of these tests are normal. So again, the choosing wisely approach for this would be to use the CT scan rule and to reduce the exposure of patients to a needless test. So there are secondary treatments that are available as part of the concussion approach. The most important thing is to make the diagnosis. So the slogan is, when in doubt, sit them out. So if they're a sports player who has a concussion or a worker that has a concussion, sit them out until they're feeling asymptomatic and have been gradually returning to activity. Treatment of the event is important. We don't entirely know the best management for these patients and what their follow-up should be, but they should go back to their primary care physician, like a family doctor or their internist or pediatrician, to get assessed and determine what their symptom profile is. And prevention of the next event is really critical. We've seen that when people get a first concussion, and if they don't recover from that concussion, a smaller, less impressive head injury or rotational injury of the neck will give them another concussion that could be more severe. So Sidney Crosby's experience was his concussion during the outdoor game was very severe, but the event that caused him to have the most problems was a couple of games later, was a relatively inconsequential hit that most people would have thought would not cause any problems at all. So again, he hadn't recovered from the first concussion, and he got a second, more minor bump and had more symptoms. So our group, led by our research team, has looked at what's called a systematic review. It was recently published. And we looked at all the evidence for early interventions in the emergency department. We only found 5 studies, which is remarkable considering the magnitude of this problem. The large bulk of these studies were not particularly high quality, so it provided really limited advice to clinicians on what to do. So again, we should recognize also that bed rest does not seem to be effective. So we wouldn't put a person to bed for a week for a concussion. There is more research being done on this graduated return to activity so that you're not resting the entire time. There are medications for symptoms like Tylenol and Advil. They don't reduce the frequency of future post-concussive syndrome or persistent symptoms later on, but they are something that can help the symptoms. And then education and follow-up are important, although we don't know the exact best evidence for that approach. So we've used patient information sheets. We try to hand them out to the emergency department patients. We have a concern that they're not really being reviewed unless an advocate is with the patient or a family member is with them. So it's really important to bring somebody like that to the emergency department. There are social media apps for concussion, and there's a concussion awareness training tool available at the Injury Prevention Center at the UBC, which has been widely adopted and is thought to be very useful to monitor head injuries after they occur. So most of the patients that we see will spontaneously recover with time. Not everybody is better in a month, and there are some people with symptoms up to 3 months. We recommend a fairly simple approach of recognition of the symptoms, removal from the activity, and some type of rest, but not strict bed rest. And then once people are asymptomatic, so they don't have headache, they're not confused, they don't have nausea and vomiting, we do a graduated return to activity. Usually it's return to work, but also return to physical activities. And so if you're asymptomatic and then you do a light walk or workout and you have no symptoms, you can increase that up to full activity. But if you have go for a light, limited activity, and the next day you have a headache or more symptoms, you need to back off until those symptoms resolve. So some people very quickly evolve and return to play, and other people have a more sort of stuttered approach to it. They have some symptoms, they back off, then they go back to this gradual return to activity. And it's really important not to push too hard because the symptoms will get worse with intense physical activity. So the final thing I wanted to talk about was primary prevention. And we used the bicycle crash experience as one of the important ways we can prevent head injuries. And so the woman that was involved in the crash with the car, she was wearing a helmet, and so you might say, well, she still had a head injury and she still had a face injury. But we know that facial injuries are reduced by about 88% and head injuries by about 85% by helmets. So they're a critically important component. We can have helmets when we ride snowmobiles, ATVs, motorcycles, bikes, scooters, skateboards. I'm always surprised that so few skateboarders and inline skaters use helmets, and they still, when you're going that fast and you hit something like a crack in the sidewalk or a pebble on the road, you really need to have something to protect your brain. So again, the evidence for bicycle helmets is very strong, but the usage proportions in communities is variable. So there are some places where it's very high and some where it's low, and it was particularly low amongst adolescents. And you know, we have had limited success with education, trying to tell people it's good for them to ride with a helmet. And even legislation by itself without enforcement has been shown to be very effective. So you can see here the helmet legislation across Canada. So New Brunswick, British Columbia, Nova Scotia, and Prince Edward Island have all-age legislation ranging from 1995 to 2003. Ontario, Alberta, Manitoba have basically adolescent and children helmet laws. And then there's none for many of the other provinces and territories. And our own experience is that in May 2002, Alberta implemented the provincial law for helmets for those under 18 only. And we had done a survey of Alberta back in 2000, and we showed that children used helmets about 60% of the time, adolescents about 30% of the time, and adults about 52% of the time. We found that Calgary had a higher helmet use proportion than Edmonton, and that females used helmets more than males. So this evidence was used by the province to implement the bylaw. We asked for a universal bylaw for all ages, and we were refused that request, but a bylaw for those less than 18 was implemented. But in February 2006, the municipality of St. Albert implemented a very innovative municipal bylaw to mandate all cyclists using helmets in all age groups. This was brought forward by Mayor Nolan Kraus in St. Albert, who's still the mayor, and we have been following this trend for a number of years. And so what we see here is those under the age of 13. We've been monitoring this with survey data for a number of years. You can see the red line is St. Albert. They were slightly higher in children under 13 than Edmonton, but about the same. And they have maintained a much higher rate since the implementation of the legislation, even in the face of legislation requiring helmets for children. In the adolescent population was very low initially, and the legislation in 2006 kept St. Albert above Edmonton. And again, you would expect these rates to be very similar over time. And so this adolescent population is very difficult to get to use a helmet, and so St. Albert has been very successful, and about 85% of adolescents in St. Albert are using a helmet. But what's interesting is that there is no helmet law for adults in most of the province, and it's only in St. Albert where the helmet law exists for adults. And you can see here that St. Albert is consistently and significantly higher than Edmonton in their use of helmets. We know from the administrative health data that patients who are under 18 years of age have had fewer admissions to hospital for head injuries since the implementation of the bylaw, and that St. Albert has had fewer events occurring in their municipality. So it's important to recognize that this not only just implementing the bylaw without, or the helmet law without any enforcement by police has been an effective strategy across the province to reduce the potential significant head injuries to children and adolescents. So the final concern is the tertiary prevention. So we know there are some long-term consequences associated with mild traumatic brain injury like post-concussive syndrome, depression, and there's a recent study showing that people who had multiple concussions are more likely to commit suicide. And this is a spiraling condition for some patients, and we really need to recognize that patients who have had concussions are at risk for depression and suicide. Repeat concussions are particularly dangerous, so a season with more than one concussion really should mandate that athletes take time out and recover completely. And we don't know what the lifetime risks are for the number of concussions, but obviously someone who's had multiple concussions should be monitored for depression as they go along. There are certain sports, obviously, that are really dangerous, and we've listed a few here. And what happens to these patients often once their mental health deteriorates is that they require drugs for their headache and pain and anxiety, and they turn to other remedies like alcohol. And so we really need services like the Brain Care Center in Edmonton, which provides long-term post-concussive syndrome therapy for patients who are in this condition. So we'll go back to the cases in the last 5 minutes. So remember, the first case was the woman who went over her handlebars across the hood of the car and onto the ground. Her CT scan is shown here, and all you can see, I don't know if I can really monitor that, but right there is a bit of blood outside the brain. Can they see that arrow? I'm not sure. Anyway, so outside the brain, it's not, the brain itself is healthy, and there's no blood inside the brain. This is normal calcification. These are the ventricles. The brain tissue looks perfect. But you can see she had a little tiny flake off her third vertebrae. This is the first, second, and third vertebrae. So she had a neck sprain and a small chip fracture that required her to stay in the hospital and be assessed. And she also had symptoms that were persistent, so she couldn't go home. So here she is now. You can see that her face has healed completely. She's neurologically intact. She's resumed bicycle riding, always wearing a helmet, and is doing extremely well. So again, the helmet probably reduced the severity of her injury. And this is not to downplay the symptoms that she had immediately after the head injury, but to recognize that the helmet contributed to taking that force that was so intense on her head. It cracked the helmet and dissipated the energy. Instead of going to her brain, it went through the helmet. Case number 2, that was the last game of the season. She was neurologically intact, felt better, had no of the high-risk features associated with the head injury, and was not provided with a CT scan. And the third case is a case of post-concussive syndrome. So a pretty inconsequential event, driving a car, turning left, your head is turned in the direction of the traffic and looking for dangers, and somebody hits you from behind. A rotational injury with a forward flexion of the head without a direct blow to the head, but a clear concussion. Retrospectively, her emotional issues worsened. She was actually forced to withdraw from her training program because she couldn't multitask. And we've had patients who have something called alexia, the inability to read after having learned to read, and they have to be retrained to read, which is a really significant problem for young people who are at school, at university, doing work. People who can't function in their daily life because they can't remember from one moment to another. And in this case, she withdrew from her training program, and we're still trying to get her back to finish her training. She had orthostatic exercise intolerance, which is where you exercise and you feel faint, like you're going to pass out. And her concussion was clearly diagnosed late. Probably doctors are their worst own enemies, but the reality is that she was only diagnosed much later to having a concussion. So just to summarize before we close the session, concussions are extremely common. The more you talk about it, the more shocked you are at how frequently people experience these. Sometimes they're not observed, and sometimes they're not detected by health professionals. So it's really important to get seen, be assessed, and to clearly articulate your symptoms. Nausea, vomiting, dizziness, difficulty focusing, fatigue, those kinds of symptoms are all symptoms consistent with a concussion. CT scans in the emergency department are often unhelpful. They offer some risk and very little benefit to many patients. So you should talk to your doctor about the risk, and we should choose wisely with respect to having a CT scan. And concussions need to be taken seriously. These are not inconsequential common colds. These are things that if you neglect them, it will be at your own peril. There are limited interventions apart from rest and a graduated return to sports or activities, but that's the best thing that we can offer at this point, and follow up with a healthcare provider. The graded return to activities, I think, is particularly important. And then services for concussion and post-concussion patients are often scarce. There are a few places in Edmonton, for example, that offer services for concussion patients. They are expanding at a dramatic rate, but many of these are pay for services arrangements, and we're not entirely sure that they're all the kinds of things that we should be encouraging patients to go to. So I'd just like to acknowledge some funding from CIHR, from the Workmen's Compensation Board of Alberta, and the Brain Care Centre for some of the studies that we were doing in this particular presentation. And I received funding from the Tier 1 Canada Research Chair Program. And we get in-kind resources from the Department of Emergency Medicine at the University of Alberta and Alberta Health Services. So appreciate the invitation from Eric and the team here, and I'm quite happy to take questions from the audience. And Eric is monitoring the waves right now. And I'm just wondering if we have anything. Eric?
Yes, we do. We have a couple questions. So this first one is a bit of a scenario for you. So the scenario is an open ice hit in hockey with no head contact, yet a high rate of force on the body and probably movement in the brain within the head. In your opinion, should that require a CT scan? Is it based on presenting symptoms more than the incident?
That's a great question. So there's no question the description of that presentation would suggest that that person is at a high risk for a mild traumatic brain injury or concussion. You're right, the rotational forces of coming down, hitting your head on the ice, even with a helmet, that person is at risk for a concussion. But the CT head rules would suggest that unless they have the mechanisms or the symptoms consistent with that, and I'll go back here, I don't know, am I still on the slides? If you look here, if the person's not vomiting, if they're not a really old hockey player, if they're not amnestic and they don't have a dangerous mechanism, and they're not confused at the time, they don't need a CT scan. So the problem with the CT scan is it only really detects a bleed or a fracture. So what we think is happening is the axonal injuries in the brain are often microscopic, so we don't see them very well on those kinds of scans, and they only show up later on in other kinds of imaging. But again, if somebody had that kind of event and then had those symptoms afterwards, that would be consistent with a concussion, and they may or may not get a CT scan. Eric?
We have another scenario for you. This one is if someone was hit in the side of the head, slightly below the temple, by a golf ball being struck off a tee, in your opinion, would they require a CT as they did not become unconscious?
Well, again, if you look at the CT scan rule, a golf ball is perhaps not a dangerous mechanism. It would depend on their symptoms afterwards. But that particular area is one that physicians are always concerned with, because that's where there's a very strong blood vessel that can bleed into the brain. So although these are rules, we may, in that particular scenario, obtain a CT scan for that patient, because we're still supposed to assess the patient and the event individually, and these are guidelines. And if I, as a physician, if I see a patient like that, and it's a direct blow, we know how hard a golf ball is, I may, after examining that patient, send them for a CT scan, because that area is so susceptible. But in general, if they had no symptoms, they weren't knocked out, and they didn't meet any of the higher or medium risk features, most people would not CT scan that person.
This next question is a bit of a hypothetical. Knowing obviously that this would be a difficult thing to put into action, in your opinion, would helmets in general public automobile accidents be effective in preventing head trauma?
Yeah, that's a fascinating question, because there have been almost every time I present, I do get a question about how far should helmet use go. You know, the modern cars are so well built. They're reinforced. They have airbags, and they have very strong seat belts. And many of the people we see now, if they use their seat belt and have an airbag, they come to the emergency department, and they really have very few injuries, maybe an abrasion from the airbag and maybe some dust from the airbag, but they are often very well protected. So I think the key there is always wear your seat belt, and not have an old clunker car like I've got in my driveway.
This next question is focusing on CTE. Are prolonged symptoms from a concussion a sign of CTE, or is CTE not seen in general public, or do multiple concussions, regardless of activity, result in CTE?
Yeah, so most people won't get, if you have prolonged symptoms, you won't develop CTE specifically, but it's thought to be the repeated multiple concussions that cause this, and repeated head trauma. So boxing, football, hockey, those kinds of sports, even in soccer. The problem with CTE is it's only diagnosed at death. So you can't diagnose it from regular scans in hospitals. So it's we don't have a sensitive test for that at this point.
You mentioned the high overload of people using ERs in Alberta and Canada. When it comes to concussion or even suspicion of concussion, when should one visit the ER versus their family doctor or clinic? Well,
I mean, I think if people are concerned, I never try to turn people away from the emergency department, because the clinicians and the staff in the emergency department are trained to detect the serious problems. If you have if you have toe jam or a stubbed toe, well, we're not very good at that kind of stuff, but we're pretty good at detecting serious conditions. So I would argue that if you're concerned, you should be assessed, and if you should not be deterred by waiting time. When you get seen, you'll be fully evaluated, and a decision will be made as to the need for additional testing. It's really difficult for people to triage themselves, and most of the time that has not been very successful. So people, they downplay their chest pain, they've got a heart attack. They come into the emergency department, are sure they're having a heart attack, and it's something else. So, the reality is you're not trained to do that. If you're concerned, or if your family's concerned, you should take the time to come into the emergency department. We're not always overcrowded, and head injuries are taken seriously. We do see those a bit more urgently than, again, the stubbed toe or the toe jam.
Another question that just came in here. If a concussion isn't treated, how long after can symptoms present? Is it months or is it years?
Well, when you're talking about symptoms, they generally come associated with the acute event. They don't just sort of, if you're well and 5 years ago you had a concussion, you won't just all of a sudden have symptoms. So there usually are persistent symptoms associated with the event. But you may actually have had multiple concussions before and get an inconsequential bump, which causes your symptoms. Again, a rear-end car collision, which again doesn't seem like much. I have a nursing colleague who tripped on the way out of the Misericordia Hospital on some ice and hit her head. She had prolonged symptoms. We have a friend who was thrown from a horse, and she's had significant symptoms associated with concussion. So it's generally associated with the event. It doesn't just sort of spontaneously start later on.
Why don't people use helmets if they're so effective?
Well, that's a great question. So, we've done some surveys on cyclists and roadside interviews, and particularly young people, the adolescent population, they don't want to get bed head and helmet head. So they like to have their hair flowing when they're riding their bike, and they don't want to have it matted down when they get to their destination. So that's one. In the old days, these helmets were relatively expensive, and nobody was using them. So and they were heavy, and people's neck would be sore after even a short ride because they were uncomfortable. Now the helmets are light. They're aerodynamic. They're often they've got lots of ventilation, so they're much more comfortable. For kids, there are different types with decals and all sorts of different types of helmets that make them look like ninja warriors or other cartoon characters. So there's a much greater variety at a lower price, and I just think that people are misinformed about them. Even people who should know better often disseminate misinformation about the dangers associated with helmet use. In fact, there's virtually no risk to wearing a helmet. The risk is not wearing the helmet and having a head injury. So we think education and enforcement are critically important. I think one of the things that Alberta Health could do in this province to reduce injuries further is to adopt the universal helmet legislation of other provinces and of St. Albert, and to follow the courageous efforts that municipality has put forward. And I would highly recommend that as an injury prevention strategy for the province.
When it comes to concussion, what should parents look for in their children?
That's a really important question, and I'm glad someone asked it. It's really important for parents, particularly of children who are playing sports, and sports can be something as simple as playing on the playground in your neighborhood at school. If your child is having is sleeping more frequently or for longer, and has maybe some emotional outbursts that are not typical of that child, if they've had a loss of appetite, they don't seem to be doing as well in school, think about concussion and think about having them seen. It's quite common for athletes to downplay a concussion, to say, oh, I had my bell rung, but I'm fine now. And we really need to make sure that we're not letting them back into an environment where they're susceptible to a secondary head injury. And I think that's, the parents have, a history with the child that perhaps the coach or the trainer might not have. And that way, the parents can detect these minor changes in behavior or in eating habits or in sleep or school performance to make sure that if they detect that they have them checked for head injury. Obviously, it could be something completely different, but it's one of the things to consider.
And what happens if the symptoms don't go away?
Well, again, the follow-up is critically important. There are some services available at places like Brain Care Center where occupational therapists, physiotherapists, and multidisciplinary clinicians are working together to try to improve outcomes. So you can see a person like Sid Crosby, he got physical therapy, he got occupational therapy. He took time to regain his skills and get back on the ice, and has had limited symptoms as far as we know since that time. There are success stories, and sometimes if your injury is significant, you need to get adaptive strategies in place to be able to live your life as normally as possible. So there are services available. Often they are multidisciplinary, and I think that's the solution for most patients. Okay, so I'm getting signals that we have to close the webcast. So I just have a few minor things to say. As I mentioned, this webcast is part of the Government of Alberta Human Services Learning Series, which will be running the third week of each month through July 2016. The series covers topics from ABII, like the one we talked about today, and there are other series that talk about Employment First, Fetal Alcohol Spectrum Disorder Initiative, and the Office of the Public Guardian and Trustee. So you can see those on the website, and I'd just like to thank everyone for joining us today. Hope it's been informative. Stay tuned for information about next month's webcasts. And to get updates and registration information about each of the sessions, please email abii@gov.ab.ca and ask to be added to their mailing list. And you can find past and future webcasts and sign up at hslearningseries.ca. That's hslearningseries.ca. You can see that on the slide. Today's webcast was recorded, and the video will be posted online along with videos from the previous webcast, so you can catch up on anything that you've missed. The video link will be sent out to all registrants in the near future, and we encourage you to share this widely with anyone you think may be interested in the topic. If you have any feedback about today's webcast, please send an email to us at abii@gov.ab.ca and let us know what you think. You will also be receiving a feedback form, and on the request of my wife and children, I'd like you to fill that out positively if possible. Please take the time to let us know what you think and what other video webcasts you'd like to see. We'd love to hear your ideas, or at least the people around this room would love to hear it. I don't really care. No, just kidding. Anyway, have a good afternoon, and thanks very much for attending.